Welcome to The Explainer. If you're prepping for your final anesthesia exams, you are in exactly the right place. Today, we're going to break down a topic that is absolutely critical, not just for your exam, but for your day-to-day clinical practice: venous thromboembolism, or VTE, in pregnancy. All right, here's the game plan. We're going to start with why this is such a big deal. Then, we'll dive into the science of what's actually happening in the body. From there, we'll walk through spotting it, treating it, and, most importantly for you, the anesthesist's role in all of this. And we'll wrap up with the key takeaways you absolutely need to know. Okay, so first things first, let's set the stage and talk about why VTE in pregnancy is a topic that demands our full attention. I want this to sink in. This isn't some rare, textbook-only condition. VTE is the #1 direct cause of women dying in pregnancy and childbirth in the UK. And what's really sobering, if you look at the MBR-RAC reports, is that this statistic hasn't really budged since 2009. Despite all the national guidance, we're not making the progress we need to. So just how big is the risk? Well, pregnancy itself multiplies a person's risk of developing a VTE by 4 to 5 times compared to someone who isn't pregnant. That means every single obstetric patient you meet is already in a higher risk category, right from the get-go. So, what is it about pregnancy that creates this incredibly high-risk state? Well, the answer isn't some new, complicated medical mystery. It actually comes down to a classic concept that you definitely need to know. It all boils down to good old Virchow's triad. And here's the crucial part to understand for pregnancy. It doesn't just check one of these boxes. No, it puts a massive tick in all three, creating what is essentially the perfect storm for a blood clot to form. And this slide really lays out that perfect storm for you. So first up, you've got venous stasis. The growing uterus acts like a clamp on the big veins, and hormones cause blood to just pool in the legs. Second, there's vascular damage. The act of giving birth, particularly if it's an instrumental delivery or a C-section, can cause direct trauma to blood vessels, which immediately gets that clotting cascade going. And finally, the body itself creates a state of hypercoagulability. It basically makes the blood stickier on purpose, cranking up the clotting factors and dialing down the natural anticoagulants, all to get ready for delivery and prevent bleeding. Okay, so we know why it happens. Now let's get into the really tricky part. How do you actually spot an at-risk patient and diagnose a clot when the signs can be so sneaky? And this is a huge clinical challenge, right? Because the classic signs of a DVT, a swollen, painful lower leg, are things that can happen in a totally normal, healthy pregnancy. It's incredibly nonspecific. This is exactly why you can't rely on symptoms alone. We have to use formal risk assessment tools. Every single patient needs to be assessed at their booking appointment and then again every time they're admitted to the hospital. You're looking for red flags like a previous VTE, that's a big one, a BMI over 3, being over 35, or having had 3 or more babies. And then you have the obstetric factors like preeclampsia or needing a C-section. And of course, immobility is always a major risk. Now listen, if you take one thing away from this section, let it be this. If you have a clinical suspicion of VTE, you start treatment with low molecular weight heparin immediately. You do not wait for a scan to confirm it. As for investigations, don't even bother with a D-dimer test. It's naturally high in pregnancy, so it's useless. You'll typically start with an ECG and a chest x-ray, and then move on to definitive imaging, like a VQ scan or a CTPA, depending on what your local hospital protocol is. All right, so we've identified who's at risk, or we're treating a suspected clot. Let's talk about the drugs. How do we treat these patients? And, just as important, how do we stop a VTE from happening in the first place? Your #1 tool in the toolbox is low molecular weight heparin, or LMWH. It's the go-to because it's predictable, it's easy to dose, and it has a lower risk of that nasty complication, heparin-induced thrombocytopenia. And critically, it doesn't cross the placenta. But unfractionated heparin still has a very important role. You'll use it when you think delivery is less than 24 hours away, or if your patient is really sick, because you can reverse its effects much faster with protamine. Now for dosing, and this is a common trip-up, when you're just preventing a clot, so for prophylaxis, the dose is based on the patient's weight at their booking appointment, not their current weight. It's so important to get this right and follow the guidelines, like the RCOG ones shown here for enoxaparin and dalteparin. Now, if you're actually treating an active clot, that's a whole different story. The doses, as you can see, are much higher, and they're usually given twice a day to keep those levels steady. As always, stick to your local weight-based protocols. Okay, let's get to the real meat and potatoes for your anesthesia exams. Let's talk about your role in all this, specifically when it comes to putting in an epidural or a spinal. This right here, this is the nightmare scenario. This is the complication that keeps anesthetists up at night. A vertebral canal hematoma, a bleed into the spinal canal, is rare, thank goodness, but it is absolutely catastrophic. It can cause permanent paralysis if you don't catch it and treat it immediately. Okay, screenshot this, write it down, do whatever you need to do, because these are the hard numbers you just have to know. To keep your patient safe and minimize the risk of that hematoma, you have to follow strict timing rules. It's 12 hours after a prophylactic or preventative dose of LMWH and a full 24 hours after a therapeutic dose. No exceptions.
And remember, just because the block is in, your job is not over, not by a long shot. You need to be vigilant about neurological monitoring afterwards to catch any problems early. A really simple way to screen for this is a straight leg race. If that patient can't lift her leg 4 hours after the last top-up, that is a massive red flag, and you, the anesthetist, need to know about it immediately. Every single unit needs a crystal clear plan for what to do in that situation.
All right, we have covered a lot of ground, so let's boil it all down to the absolute must-know, high-yield points for your exam and for your practice. Look, if you forget everything else, please burn these 4 points into your brain. 1. VTE is the #1 killer. 2. Always risk assess. 3. LMWH is your go-to drug. And 4. Know your neural axial timings cold. 12 hours for prophylactic, 24 hours for therapeutic. You get these right and you are well on your way. And I'll leave you with the final thought. A little scenario to run through in your head because you will face this. Your patient is on a full therapeutic dose of LMWH. She's in labor. But it's only been, say, 18 hours since her last injection. An epidural's off the table. What are her options for pain relief? What are your options if she suddenly needs an emergency C-section? Think it through now so you're ready for it then. All the information from today's deep dive comes from a fantastic 2021 article by Kearsley and Stocks in BJI Education. It's a great read if you want to learn more. That's all for this explainer. Thanks for joining me, and good luck with your studies.